Wonderful. Welcome everybody as you are just joining us. It is Wednesday, it is Thursday, not even Wednesday, it's Thursday, the 7th of December. And we are in Cardiff, and we have to report dark and wet in Cardiff at 2:30 in the afternoon. But you're all extremely welcome. Some names I recognise from some of our previous webinars, some names are new. So if you're new, absolutely welcome. And the other webinars in the series are available on the Cardiff University YouTube channel. So my name's Prof. Fiona Rawlinson, and I work in City Hospice, Cardiff, as a consultant in palliative care, but I also run the courses from Cardiff University. And also with me on the call is my colleague, Catriona. Catriona, do you want to introduce yourself?
Hi, my name's Catriona Seed. I'm one of the clinical nurse specialists and education lead at City Hospice.
Fantastic, thanks, Cat. And Karen?
Hi, I'm Karen Smith. I'm one of the clinical nurse specialists at Marie Curie, and nice to be here.
Fantastic, thank you. And we hope we might be joined by our colleague Jo Hayes, Medical Director of Marie Curie, when she can join us. But for those of you who know us before, you'll know all of us. We're absolutely passionate about sharing palliative care experiences amongst us all, because this is something that we are all doing in our different ways. We do tend to start, though, with just, in a sense, double checking who's on the call with us today. So we do have a couple of polls that would be really appreciative if you wouldn't mind answering. And I'm sure if you've been here before, you're saying, oh, we're going to answer again, but it just helps us to know who's on the call. So the first one is just, what's your main role? So if you wouldn't mind just answering that, that would be fantastic. And that's wonderful. That's lovely. So at the moment on the call, we have got some allied health professionals, welcome, and some nursing and residential home staff, welcome, and people from the palliative care team. Great. Okay, thank you. That's great. And we have a second question, I think. That's right. Thank you, Charlotte. In what setting do you work? I'm sorry, I should have said Charlotte Stevenson is working hugely actively behind the scenes, helping the webinars to be a smooth success. So a big thank you to Charlotte and the CPD unit. So yes, the second question, in what setting do you work? Would be really helpful just to know. Thank you. And in a sense, it will be really important, I think, for this particular webinar to feel able to share some of the challenging questions, but also hopefully some of the tips and tricks that everybody has found works for them when we're thinking around communicating with residents, with patients and their families. And we might find that we're talking a little bit about interprofessional communication as well, because the tools of the trade are just the same. We just use them in a slightly different way depending on who we're talking to. And so I don't know if we've got the results of the.
Yeah, they're in the chat, Fiona. So
we've
got.
Chat. Sorry, well done.
I can read them out to you. There's 25% community, 25% nursing home, 37% mainly specialist palliative care, and 12% are a mixture.
Brilliant, great. Thank you, folks. That's, as I say, we come at this topic from all sorts of different directions. So this is the chance over the next just under an hour to think around effective communication. What works? What has seemed difficult? What phrases might people use? That's the deal. And rather than have many slides, we have a few slides to share. But actually, this is really all about us all and communication. So I wonder if you want to pop in the chat. Have you got some key questions around communication that you are frequently asked, or that you've been asked recently, that you have questions about? And in a sense, while people are thinking, and please use the chat, we can unmute microphones when we need to, but please use the chat. Just thinking for myself this morning, we were in a care home this morning, in a nursing home this morning in Cardiff, and a daughter of a resident was just saying, I don't know what to expect. I don't know what to expect. My mother has just moved from her house into this care home. And I've got a son who isn't very well at the other end of the country. I've got a son who's going to New Zealand. I don't live here. I live over the border in England. And I just don't know what to expect. And the lady that we were visiting was quite stable. She'd been in hospital with a chest infection, but she was settling in very well, but we weren't quite sure what was happening. So that was one of our questions this morning. So do please add some questions into the chat. What questions have people asked you? And what questions have you got? What will help the most? And I don't know, Karen, just sort of thinking from your perspective as people are thinking, what tends to be the questions that you've been asked that have, well, perhaps let's go with what's the regular questions that people ask you when you're there?
Sometimes it'll be something along the lines of, why has Marie Curie come to see me? Because they may not have taken on board what's been said to them, or they're scared that we've been sent. And it's like, well, you just deal with death and dying. And or they haven't got a cancer. So why am I seeing you? You're Marie Curie. And so it's these questions that come up a lot. How long do you think I've got? And the other one, obviously, we tend to see a lot of is I think I'm dying. And so it's never dismissing them, but asking them specifically why these things. But yeah, so Kat's got the same sort of things happening when she sees patients, but it's dealing, and your lady, that's a lot of questions and a lot of worries, isn't it? It's picking it apart and trying to work out what the bit she's really worried that everyone's going to be away and she's not going to be there when mum dies. It's those sort of things that I think families worry about, don't they? Should they bring Christmas forward, especially this time of year? So lots, and I could talk about it for hours, as we all could. So I'll be quiet now.
Yes, and Catriona, what again from your point of view?
And like Karen says, there's so much, isn't there? You think about sometimes when you think back to your first session from the webinars, Karen, where you talked about advanced care planning. And people are often very frightened about what the future will hold. What will the future look like for me? And sometimes it's almost the enormity of it, isn't it? They're so overwhelmed by the diagnosis, a potential prognosis, all these problems happening at once. Then when you actually try and funnel down and unpick what's going on, actually sometimes it can be just one or two things that is really worrying them. It could be something as simple as, I'm worried about my symptoms. Am I going to suffer in pain as I'm dying? Am I going to be sat there gasping for breath? Or sometimes it can be something so important like, how is my family going to cope when I die? And that can cause such existential distress. And it's so important not to forget that aspect. So that's quite an interesting one to sort of pull it whenever people are talking about being frightened about the future. It's a huge area and you've got to really tease out the answers from people. There were some lovely thoughts, I thought, as well, when people were sharing stuff in that first session. And I don't know if anyone's here, but someone left the most lovely comment in the chat on your first talk in advanced care planning, saying that there was a desire for something higher to fill their mind and relieve their emotional burden and lift their fears as they were thinking about the end of life. And I thought that was a very beautiful way of thinking about that more spiritual side when they're planning for end of life.
There's a thanks, Neve. Thank you, Kat, and thanks, Neve, for starting the chat around. I work in the community, how to get patients on board to gain their consent to refer to the palliative care team, picking up exactly what you both have been saying, especially when they aren't end-of-life frail elderly patients. I think that's a really interesting question, Neve, and from a doctor's perspective, from my medical perspective, Sometimes I've used the symptom control. If there are people who've got symptoms, sometimes that can be a little bit easier in terms of there is a clear and present reason the person is suffering from something. And I sometimes say, look, whether the palliative care team can be there to help support the GP and the district nursing team. So really wanting to give the impression that we are all working together. You don't want to, I think people sometimes fear, don't they, that they're going to have a whole new different team and have to get a whole new different lot of people, whereas actually we're kind of the glue, really, or the oil, part of the oil in this great machine. So sometimes I've found that works. Sometimes I've found that you don't almost have to do it all at once. So it can be a drop, a suggestion, and then leave it. Doesn't have to be answered at that point unless it's an emergency or urgent. But sometimes time can help, because sometimes people need time to reflect and think things over. I don't know, Catriona, go to you first on this one.
Yeah, well, we've got a lovely case in point of a gentleman that I've actually done my follow-up visit. He was met by my colleagues for the first time last week, following a referral to our services. And as a routine, we always introduce ourselves the following week. And a lovely man, he was very open and honest and said he was absolutely petrified of our loveliest consultant because he realised he was a palliative doctor. And he talked, they were exploring some of the ACP conversations and broach resuscitation, and we won't be doing that for a while. We've been told very clearly not to touch that for a while. But what was really lovely was seeing that reassurance of he realised what our role was. And actually, we'll pop in regularly, keep an eye on symptoms, help him plan ahead, make sure he's got the support he needs. And you could see that reassurance coming through that actually palliative care isn't what he thought it was. People still really do think that palliative and hospice care means that I am imminently dying. You're coming here, the nurse of death, the doctor of death, because I am dying. And they don't appreciate that we are here for the long haul. And that's really important. You gave that lovely example in your comment there that you're wanting to refer people that aren't end of life, but maybe are frail, maybe they're a bit elderly and they do have palliative needs. And is that reassurance that actually we are there to improve people's quality of life. And that's really powerful. When people understand that, it's amazing the difference we can make to people.
I sometimes say palliative care isn't so much about dying, it's about living.
Yeah.
The actual palliative care bit is the quality of life right up until that last breath, because if you get the quality of life as good as it can be, and it might not be perfect, but if you get it as good as it can be, then the experience of the families who have done that journey with that patient, or yourselves as carers in care homes, will be just that little bit different. So I think, I don't know what we call it if we didn't call it palliative care, but I think palliative care is about living. Karen, do you want to add something?
I think I agree completely. I worked as a frailty nurse for a while in between doing specialist palliative care, and there is that, because of the roller coaster that this family are on, you're dealing with a lot of stress from families as well. And funny enough, one of my colleagues this morning has just posted on our group chat the article that she's reading today, which is the one that says, "Thank goodness you've come." So yes, there's always that worry about us coming and being involved. But we are there, like Fiona says, we're there to improve quality of life. That's what our role is. It's to make sure that they don't undergo unnecessary treatment, to make sure that their voice gets heard, all those things that, like we say, it's tying up the team around them. And we're very lucky. We work with some fabulous teams, but it's having one point of contact really sometimes for them as well, that they can think, oh yes, I'm going to speak to you now. But the frail and the elderly, absolutely, they are as much our sort of welcome to talk to us about things like advanced care planning, and there's certainly when they've had lots of hospital stays, those things become important. There's all the we call them the sentinel events, don't we? The moving into a care home, having frequent admissions, frequent infections, and actually us coming along, it might be that they want to talk to you about things that they might not want to talk to the family about, like antibiotics and things, and they worry about pain, and the breathless patients, they're the ones that are worried about being breathless, and we know we put the advanced care plans in place for those breathless patients. Chances are that when their respiratory rate is creeping up and they're getting tired, they're going to want to go into hospital. But we know that as soon as they're well enough, they want to come home. So it's putting those things in place. And I guess, Neve, you probably do a lot of that anyway with your patients. If you're working in the community, you've probably had those conversations, and it might be that you never actually need to refer to a specialist team because you've managed it really well with the team around you, and you've not needed to speak to us, because a lot of the skills that we'll talk about today are about having those conversations.
And I think absolutely. And I think that part of the trick with communication, isn't it, is trying to get that right atmosphere. So get in the sense, so people talk lots about comfort, about communication, but actually it's not just the physical comfort, and physical comfort is very important, but it's actually psychological comfort as well. So if you're busy doing something, I don't know, checking a bed, doing something around a bedside table, doing curtains or whatever, it's quite difficult sometimes to be able to show that person that you're listening. But not everybody's the same. And do you know what? Sometimes I think that the skills are the same, whatever age you are. So, that thing about perhaps talking with teenagers, if you sit down and talk across a table, generally it doesn't always go very well. But if you are in the car, not quite looking at each other, or standing at the sink doing the washing up, doing something, for some people, actually, that is their psychological comfort zone. And so we are endlessly unique. And so for some of my conversations with more elderly patients, it's actually I am fully attentive and listening, but sometimes it can be while I am listening to the chest or taking a blood pressure that actually they will answer and they will come out with some of the things that they're thinking about. I think communication is one of these things that we will all continue to reflect on and wonder about and practice, and sometimes feel that we haven't done things well, sometimes feel, oh, that went better than I thought. And it's one of those lifelong skills. And actually, I think in some ways, I think it needs to be a lifelong skill, because we all develop habits from time to time. We all have our own internal worries from time to time. And if those come through, they might block some of these really sensitive but really important conversations. And I think the role of families is so important, but families, as we all know, are so diverse in their needs, their information needs, but in their communication styles. I can remember looking after two ladies in the inpatient unit down west along the M4 a number of years ago now. Two very similar conditions, lung cancer, with some bone metastases right at the end of life. One lady had a family that was in all the time, in and out, in and out, in and out, and there was lots of noise and jollity, even though, she was the end of life. Another lady's family lived locally but didn't come in, but that's how they communicated. The first lady didn't like music, the second lady did like music on as a background, and it was about working out for that person and that family what was right for them. And you'll know all of this from all the different residents that you look after. I wonder if it would be helpful just to share some ideas on a couple of slides, but please do use this opportunity to share your thoughts, because I think all of us on the call will have had communication situations that have gone very effectively and gone well, and all of us will have had questions that have been unanswerable and made us perhaps feel very awkward and unskilled. That's communication, that's what it is. But Kat, shall we just share some slides to start with and just see, but please keep adding your things to the your thoughts to the chat. Fabulous, that's looking good.
Okay, can we all see that?
We're nearly. Yes, we can.
Yeah,
There we are.
lovely, brilliant. So I think we've already done the introduction, so we'll
I think we have, yes.
Excellently. Fab. So I think you've already got a feel for that. We won't hang around on that. So I think we wanted to start just a little bit, just to talk about sensitive communication. And I think we've already alluded to this anyway. But for those of you already familiar with maybe the care decisions, maybe you're familiar with the 5 priorities for care of the dying person. Sensitive communication is the second priority of care for the dying person. So making sure that we're communicating with the dying person and the people important to them. But I usually say we need to be sensitive with each other as well, because we all look after people. We're all human beings. And it's really important to support each other when we're looking after patients at this time. I wanted to throw this at yourself. So I don't know if anyone wants to put into the chat, or if Fiona or Carol want to bring any nice examples. Just thinking about a time maybe that you've had to break some bad news, or maybe you've had maybe just a challenging conversation with a resident or with family members or someone else that's important to them. And how did that conversation go? Did it go okay in the end? Did you find there were any particular challenges with it? Does anyone have anything they want to bring to the group? I know
Shall I? I'll share a DNA CPR conversation, because I had a gentleman, this is going back a couple of years ago, who had dementia. He diagnosed with dementia. Lovely gentleman. Used to like to bet on the horses, but he was determined he did not want to go back into hospital. This was something long-standing. Didn't want to go back into hospital. Wanted to stay at home. Wanted to die at home. Was looked after by his ex-wife, who was doing a fabulous job, but there was a son who didn't live with his father, who would come to visit once a month up from London, who worked in somewhere in the legal industry. And when Dad had said he didn't want to be received, I had a conversation about, well, you don't want to go back into hospital. One of the things that might make that happen would be if your heart stopped, a crew might come, and we talked about DNA CPR. And he's like, well, what's the point? I'm dying. I've got cancer. I want to die at home. I don't want to go back into hospital. They're not going to fix it and make me better, are they? And I said, no, it's very sensible. I agree. I'll speak to your doctor and we'll get this. And this was actually working as a frailty nurse at the time, and went back to the GP. We agreed, absolutely. Did all the paperwork, got that signed. Son saw the paperwork when he came to visit, was up in arms because Dad has dementia. How dare you have this conversation? It said he wanted to see us, so we went there. We had a conversation with him, and one of those very sort of tall gentlemen who insists on talking at you above your head height and wouldn't sit down in the room. And it was difficult, because obviously the gentleman was absolutely had capacity to make that. Yes, and this is the thing when we talk about capacity. He knew what he wanted. This wasn't something he understood. He understood that by saying that he was going to stay at home, that he would die. That's what he wanted, and you could see him getting more and more frustrated. And he just sat there and was like, I don't want to go to hospital. I don't want to be resuscitated. Why would you want to do that to me? So it was advocating for him as a patient at that point, which is a sort of a change around, because you're there sort of saying, well, this would be the reason that this is a sort of a treatment that we do to somebody to sustain their life. There are chances that you will sustain damage when we do it, because it's a very violent procedure. So all these sort of conversations that we sometimes have with patients when they ask what we do, and we're honest with them about what happens. They didn't even come to that, because he did not want to be resuscitated.
Yeah.
And his ex-wife said he had been like that for probably about 10 years. He was in his late 80s. He felt he couldn't get out of the house anymore. He didn't want to have this done. So that was a difficult conversation, and one that was lucky the GP was all for coming down and being in the meeting as well. But we said, well, we'll go in gently at this point, and then, but this man has a choice, and it's a clinical decision if the GP says, but very difficult. I know we've all had those.
And so, Karen, just thinking back to what you've just described, how did you approach, I'm not so much thinking of the exact words you used, but actually how did you approach handling that situation? Because of course the situation had the patient, the ex-wife, the son, but there are people in a room, and you and possibly the GP. What were you thinking of as you were trying to contain the conversation, or what helped to have that conversation to flow? Because inside you must have been feeling very anxious, I would have thought, but you won't show it because we don't, do we?
No,
but
no.
yes, what was your plan for actually how to conduct that conversation?
It was trying to keep things as calm and as contained, and to allow him to rant, because he obviously felt he was justified in having a go. But when he finished that, saying, okay, I understand what you come, and I said, but I think that you need to also understand that your father knows what he wants. This isn't something new. This is something, and actually looking back through the clinical records, at times when he'd been in hospital, that DNA CPR had been put in place, and obviously he'd come home and they weren't aware they had one. The GP wasn't aware there was one in place. So that's that thing about communication as well, that it's very difficult sometimes when there isn't one place where this thing is held. But trying to just de-escalate this gentleman in his 30s from thinking that we were trying to euthanize his father, because that's what he kept. It's a very emotive word, euthanize, and we'll sometimes have that, won't we? Or we either have that end of the spectrum, or we have the "you wouldn't do this to an animal" conversation, and we have to explain, we're not there to hasten anything, but we're also not there to prolong somebody's life, and it is about quality. And it was just trying to reassure him, and it was a long conversation that eventually I think he listened to he actually listened, probably I think more to his mother, saying that he doesn't want this, and she was getting upset, bless her. This was not a conversation we'd already had it, and had been upsetting on that. And I think, if reflecting back on it, I think probably if I'd realized that he was going to come in like that, I probably would have asked for him to be there for that meeting to discuss that. But it's very difficult when someone's not in, that isn't local. Sometimes we go and there's maybe 5 or 6 members of a family there when we turn up, and that's actually sometimes easier because you can have that conversation. But this was an only son, lived in London, he came down at weekends, and so it is difficult. But reflecting back, I think there were things that I probably would have done, and sort of maybe rung him and said, look, this is what your father wants. I suspect his response would have been the same. But it is difficult, especially when it's usually someone that isn't there seeing that decline, that's expecting, and saying to him, actually, this is something that we do. It is a process that is not pleasant, and having worked in A&E and broken ribs in the past, I've wondered about whether I should be resuscitating someone who's in their late 80s, who's come in, who's maybe housebound, and you're hearing all of these things and thinking, oh my goodness, they've come into A&E, this is where they're going to die, or at least that's where the death is going to be recorded. But it is a very difficult. But I think that, looking back, I wish I'd asked him to come down. I suspect he would have said no because he was busy. But at least I could have said, well, these are conversations to have. But his dad got what he wished. He wanted to die at home, and he did. He died at home peacefully with his ex-wife there looking after him, which is what he wanted. But it was a difficult conversation. So.
And I think, thank you. And I think it really highlights, doesn't it, what I've put in the chat. I think anger very rarely are people born angry. Very rarely. Anger comes from somewhere. There's something driving it. It's an emotional response to a situation, whether it's fear, whether it's anxiety, whether it's feeling out of control, and whether it's perhaps being shocked. So if people who live away come and their loved one is suddenly different from how they were before, suddenly something, end of life that was sort of something that happened to other people, suddenly people might realize, and their defensive mechanism is to become angry. And so I think part of our tools, if you like, is recognizing that it's rarely directed directly at us. It's usually a response to a situation. And if we can, to prevent it being directed at us, it's just trying to let it out, trying to understand what it is that's driving it. And usually, if you can allow time, there comes a moment in a conversation when it shifts. And sometimes people, if they're not usually displaying anger, will say, "Oh, I'm really sorry. I'm really sorry. I felt very strongly about that." But I think part of the skill sometimes can be recognizing the need for people to be able to offload, but recognizing that when there are times when, despite the busyness of the day, the success of future conversations actually depends on how this one goes. And that can be so hard when we've got competing priorities on our time, and lots of call bells going off and lots of people around, but actually it is sometimes these things are one conversation at a time. I think that's a great example. Anything else people have got suggestions about or questions about these conversations? So, yes, thank you. Yes, anger and confusion and anger and frustration. It's difficult, isn't it, when people's behaviour may be as a result of their condition. I don't know whether that's also possibly what you might be saying, Olubunmi, whether sometimes people, for example, with dementia or with brain conditions or brain metastases, can become very aggressive and angry, and it can be quite difficult then to be alongside people and to try and calm the situation down, which inevitably impacts on relatives. And I don't know, I mean, Catriona, in your experience, when you've been to see people in that condition, have you got any sort of suggestions for how you've managed it?
I think it's not just the patient, is it? So when I was teaching the other day in another session, one of the nurses there brought up an example of challenging communication where the relative had been very angry and quite confrontational, and it turned out afterwards they managed to calm the situation down, but she had mental health problems. And obviously, if you've got anything else going on in your life, and then your loved one is seriously ill and potentially dying, you've got all of that on top. And I think sometimes we forget this isn't just about them having the conversation about their loved one dying, and it may not be the conversation about you are dying. What else is going on in their life? If they're living in the nursing home, how long have they been there? Have they only just moved to the nursing home? Have they been settled there for a long time? Like you say, if there's another condition going on in the background, so how well are they able to take on board the information that you're giving them? Sometimes with some of these conditions, particularly some of the dementias, there can be an element of paranoia, and that can be really difficult. I think the most important thing that you can do is show compassion when you're communicating. I think you need to be open and honest in your communication. And I think you need to be very open about the limitations, not just of the situation, but of your own knowledge. We don't know everything, and we shouldn't pretend to know everything, because if we pretend, people aren't idiots. They know we can't possibly know everything, and we will destroy a trust. And if we're destroying a trust at such a sensible and such a sensitive and delicate point in time, that is lost, and we will not have time to get it back. There's a bit of a waffly answer there. I'm not sure if there was a, but I think it's really important, no matter what the situation is, whatever the emotional output that's going on in front of us, we need to treat each individual with compassion, with openness and with honesty. And really, like you've both said, just listen to what's being said at you, because what's being said will give you the keys to open up the conversation further and hopefully address what's underlying things.
Yes, I think it's the listening, isn't it? And trust is, that's what people need to feel. It's absolutely vital. What about the next thing we were thinking about, Katrina?
I think it's sorry, I'm diving ahead there. It's a common thing, isn't it? I think I've taught in a lot of nursing homes and also in other teachings with other healthcare professionals. And this is sometimes one of the hardest things, isn't it? You've gone into a lovely resident that you've known for a long time, and they're sat there, they're not feeling that great. And they suddenly turn around, you say, "Oh, nurse, I'm not feeling well. Am I dying?" I'd really like someone to come back and tell me what are you going to do? You've literally, say you're at the curtains, you're opening up the curtains, and all of a sudden, then the resident turns around to you and says, "Nurse, am I dying? What are you going to do next?" How would you respond to that?
Please feel free to put some answers in the chat.
Put your hands up, there's a raise icon, or just unmute your microphones, because I think it's really interesting to get your viewpoints. You're there on the ground doing this as well. I know when I did a teaching session in a nursing home earlier on in the year, and one of the nurses asked me, "Well, what do you say?" You know, it's something I find quite uncomfortable. What do you say if a resident asks you if you're dying? And I'll be honest, yeah, absolutely. But, how do you feel? Absolutely. Ask them why. I think I said to this particular group, you know what, grab a chair, sit down with them. Just start chatting. What makes you ask that question today?
It can sometimes be a brave question, can't it? It can sometimes be a sounding you out question to see if you're going to say the same thing as the previous person, or that's in my experience in my role. But it can be a brave question to ask, and I think we need to honour that and respect that. So I like that. How do you feel, or how are you feeling, or what is it that makes you ask that question? Sometimes can be a response, but you have to be a little bit careful that it doesn't end up being a sort of a question and a question. But what, in a sense, you're wanting to ask. In my head, I'm wanting to ask, why are you asking me that now? What is it that has made you ask that question? And for some people, actually saying it exactly like that. So that's a really big question. What is it that's made you ask that now? That can sometimes be a response, but you need to have time to hear the answer. It is a big question. So I think, to me, that's definitely warning bells. This needs time. This needs time.
And what's really important is sometimes that person isn't dying at that point, but maybe they're not feeling well. Maybe they've been worried about something. Maybe they've had in the back of their mind something going on in their family or their life. Actually, this is such an open question. And if we say, how do you feel? If we open this up right, we can get invited into such an important conversation. It might open the doors for advanced care planning. It might open the doors for an important goal for that person, something that is vital. They're inviting us to talk to them about something, and it is so important to grasp that and bring that conversation to the high. Sorry, Karen, you're going to say.
I was going to say, I had a patient ask this, and the background, when I said, "Oh, why are you asking me this? Has something happened?" And they said that they'd been told by the consultant that they would see them in 18 months. And he said to me, I don't think I'm going to be here in 18 months.
Yeah.
And that was a chance for us to talk about putting plans in place for what he
Yeah.
wanted. But that was that I don't think I'm going to be here then, which was absolutely
Yeah.
reasonable.
Yeah.
So what did you say, Karen, when he said that to you? What did you say? Can you remember what you said at that point?
So he said, said that they'll see me in 18 months. I don't think I'm going to be here then. And I said, well, I think that that is a possibility. I said, if you were to ask me, in my opinion, I would say that there is a chance that something could happen that would mean that you could die in that 18-month period. I said, but should we maybe look at putting some things in place and talking about how you would want that to look in terms of family and where you want to be? And he said he was going to have a chat with his daughters and he would get back to me about it. So actually that consultant had done a fabulous job. And I said, well, it's good that they're not wasting your time bringing you in for appointments. You're already on maximum treatment. You go and this exhausts you going to the hospital to see the consultant, and then the next day you're really, really tired. So actually they're doing you a favor and they're giving you some quality to that time rather than dragging you in when they're not actually going to do anything other than see you for 10 minutes and say, yes, exactly as you were before, I'll see you in another, as it always was 6 months, and suddenly it was 18. So it was a good thing because it had him thinking, and obviously it was quite a big thing for him then to say, I don't think I'm going to be here in 18 months. And I was like, I think that that's a really good assumption as well. Let's start putting things in place and, hope for the best, prepare for the worst, and do as much as we can, which he was a very pragmatic gentleman. So for him, that worked really well.
Yeah.
And I think sometimes families are that people will ask their families, don't they? And I think the temptation very often within families, particularly if there hasn't been open communication, is for families to not feel able to, not want to open up a conversation that will include loss and facing the death of their loved one. So very often you might overhear them say, "Oh no, you'll be fine. You'll be fine. You'll be here. You'll be fine," rather than actually, giving people that opportunity. And that, from the family's point of view, that's collusion, isn't it? Again, that comes from a place of love. That comes from a place of compassion, not wanting to upset, not wanting to have a difficult conversation, but actually for this sort of conversation, honesty around end of life might help it to be a little bit smoother, but it takes some bravery. So sometimes sort of supporting families can be important as well, but it can also tell you quite a lot about how families communicate, and if there is collusion going on, which is where some people withhold information because they're wanting to protect, that can then lead to complications, can't it, later on, and can sometimes make actually recognising and talking about those last days of life, which we'll talk about next week, that can sometimes make that a bit more complicated. So great suggestions so far in the chat. Has anybody got any other ways that they would approach that question? Anything else that people will do? Because I think this is the fundamental question, really, isn't it? This is one of the ones.
And I think it's that invitation, isn't it, to speak? And that's what's so powerful when someone does turn around and ask you this. There's so much you can get from that conversation.
Yes, lots of information.
There's some nice openings there, like what makes you want to ask that question. And you'll know your residents, you'll get a feel for what kind of language you want to use them as well. Shall we have a little look at the Cardiff 6-point toolkit?
Let's just sort of think it's fabulous. Yes. So thinking about all what we've talked about so far, colleagues here in Cardiff have really sort of thought about all of these conversations and come up with these 6 tools that everybody will be using, but you probably don't realize you're using. This morning, I probably used some of them, and I'm sure I didn't realize exactly which ones I was using all the time. But some you can learn to use in particular situations. So the 6 tools for good, effective conversations, and these work with parents, with teenagers, with children, with partners. These are useful general communication tools. Trust me on that one. They're comfort, language, question style, listening, reflection, and summarizing. And they're tools. They don't have to do them in any particular order. They're tools that you use to help these conversations to flow. And as we said, the comfort is not only the physical comfort. If somebody's got pain, if somebody's vomiting, they're really not going to be in the right place to have sensitive conversations. So you need to think how can we make them more comfortable. But it's also that psychological comfort. But it's in 2 places. Well, it's all the way through the conversation, certainly as the conversation starts, but also as the conversation ends. So actually, how are you going to close a sensitive conversation down and enable that person to get on, or enable you to get on and get out of the room or go and see the next person? Language is really important, and it's not just the words that we speak, but it's the whole thing. It's body language. 55%, over half our conversation is non-verbal. So what are you picking up from the people in front of you, but also what are they picking up from you? Are you a fidgety when you get a bit anxious if you're asked anxious questions? I sometimes am, and I've had to really learn to just really even sit with my hands together or try not to fold my hands because that's very closed. But actually, what is your non-verbal language, the non-spoken language, the unspoken language? And think, if you're talking to people over the phone, if you're giving news over the phone or giving an update over the phone, people won't see you. They'll hear your voice and they'll hear the speed of your response and the speed of your voice, but they won't be able to match it with what you look like, and you won't be able to match their voices with what they look like. We have to use the phone, of course we do, but we need to understand that it's not the same as verbal. Question style is so interesting for these conversations. So the closed questions are yes and no. Are you in pain today? Yes or no. We use closed questions. They're not bad. They're tools for a direct answer. They're not good for exploring. But open questions, tell me how you feel about that. You'd like to think that those would give lots of information. But sometimes for some, and they do, but sometimes for some people, if it's sensitive, it's actually too big and too broad. And so this third question style, this has completely changed my success in terms of having sensitive conversations. The hypothetical question is the question that sort of belongs to somebody else. So it's, have you ever thought about? Have you ever wondered if? Have you ever wondered what you might feel when you were less well? So for these end of life sensitive advanced care planning conversations, if the open questions seem to be just people won't want to answer because they don't want to unlock this whole great collection of difficult stuff, try a hypothetical question. And have you ever wondered if? Had you ever thought you might feel like this before? Some people find, that's a phrase that I use a lot, some people find it's actually quite helpful to talk to their family. I know it's difficult. But the other thing about question style and questions is try not to ask more than one question at a time. And that's really difficult. But the reason for that is people will answer the last question that you ask. So sometimes, very often, when one is feeling a bit anxious and a bit nervous, it's easy to ask more than one question. Save your voice, because they won't answer all of them. They'll just answer the last one. They say our conversation is 20% talking, 80% listening in the sort of the listening and question style. And if you ask more than one question, you're using up too much of the talking, too much of the listening style to them. So listening is really important, and show that you're listening. Nod occasionally, perhaps say occasionally. If you say it too often, it can sometimes block communication, but you have to be present. People want you and your ears and your thoughts. They need to know that they are being listened to. And a useful way to do that is the fifth tool, reflection, which is where you might reflect a word or a phrase. So, for example, this morning somebody said to me, "Oh, I feel really, really tired today." And I could have said, "Oh, tell me a bit more about that." Or I could have said, "So tell me, why are you feeling tired today?" But actually I just said, "Tired," one word, and bang, out it came, and it was a physical tiredness and a mental tiredness. So reflecting back a word or a phrase, or even saying, "A few minutes ago, I heard you say da 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 da. I heard you say this. I heard you, we were talking about this." It just shows that you're listening. And then the final tool, which can be really helpful, particularly in situations when you're getting a lot of information all at once, is to summarize what we've talked about so far. So we think of summarizing at the end of a conversation, but no. Do it in the middle. Do it if you're stuck. Do it if you're not quite sure what to say, because families have said, "And did she tell you about this? And did she tell you about that?" And actually it can be, so hang on a minute, let me just see if I've got this right. We've talked so far about, you're afraid of going back into hospital again, you're not feeling particularly well today, and perhaps your family is coming up from England later on. So you can use it to keep a conversation back on track. So these are 6 tools. They're not a framework, they're not in any particular order, but just have it just for the rest of the afternoon when you're back in on shift, when you're back working, just listen and look and just think to yourself. You'll be using all of these tools, but there are some ways of using them really effectively. It's like any tool, like your B&Q tools to do it yourself in your house, but they can be really helpful. But it's the listening, the language, the question style, reflection, the comfort at the beginning and the end, as well as in the middle, and that's physical and psychological, and then summarizing. So I'm just thinking, please pop questions in the chat, give us some examples. And while you're thinking, I mean, Karen, just starting with you, is there anything sort of else that you would add to those tools? Have you got additional tools to the words that you're conscious that you use?
I think the toolkit is fabulous, and I think sort of having come from a social services background years ago where we did solar and the skilled helper, this builds on it even more. So all the skills you learn there, and this just takes it, as you say, we learn to communicate and we continue. It's not a finite thing that we learn. We're learning all the time, and I think that holding space for someone to answer is a good point, and reflection is a way to do that. Reflect back, as you say, even just that one word can be enough of a clue for them to and they may not want to talk about something, but they might have dropped it in a big spurt of information at you, and then there's actually one little bit you think, hang on a minute, can I just bring you back to that word, and we'll just expand on that. But it's listening is the biggest communication thing, I think. Listening effectively and reflecting back what you're hearing and summarizing. There's just all of those comforters. Obviously, that's sometimes difficult when we're in an environment, especially when we're in the community and we're relying on going into other people's homes, because we can't set up a room the way that we would like to do it. So you might find yourself sitting higher up than somebody. You might find the table in the way. You might find that the heating's on, and you're a menopausal lady. You don't want the heating on. You're already bright red. But these things, I think for those of us who are in the community, it's sometimes harder because we have the environment that person lives in. So we try and even if it's sort of sitting beside them on the floor and going through things, so that you can try and not create a barrier by being up higher, or being aware of their sort of preferences. If their hearing's bad, sit on the other
Mm.
side, those sort of things. But
Mm.
it's a very reactive. You can be partway through and think, I don't think they're hearing me, and they're just nodding, and you move around and suddenly you're getting more from them. But
Mm.
it's a great tool. It really is.
Yeah.
And yes, and Kat, anything else that you would add? And then I'll come to the Tanya's in a minute.
I think being present in that conversation, just demonstrating, letting them speak. Sometimes it's so easy in conversations, we're rushing to give a reply. Don't rush, take your time, be there in the moment with them. It's amazing how often, if you take your time, especially say, for example, you're talking to someone, they've had that conversation, am I dying? You've maybe said, actually, I am concerned that you might be coming towards the end of your life, and they've got to take that on board, haven't they? That's a huge deal. If you've actually had to sit down with someone and say, actually, I think you could be dying, how would you feel if someone said that to yourself? You would be shell-shocked. Even if you felt deep down that that was true, you would still possibly need a moment or two or even longer to process that information. So let them process it. Just be there with them in that moment. And I think, again, it's one of those moments that can be quite powerful. If you allow that person to process that information in the time that is right for them, they will then respond with what is important to them. And it might be just as simple as a thank you. I just needed to know. Or it might be, oh, well, I just want to see my cat again. Or there was a lovely example. One of my colleagues, they spent some time with the hospital palliative team last year. And when they explained to the person that they were going to be dying and they were going to stay in the hospital for end of life care. And she said, you know what, I just want to see some blue sky again. So they got her in the hospital bed, they got her down in the lift, and they got her into the gardens. Luckily, it wasn't raining. But yeah, it was in May, beautiful weather, and that person got to lie under the blue sky again one more time before they died. So, and that wouldn't have happened if that person hadn't been given space to think and to express what was important to them.
And I think that's a really important point. And that bit about being comfortable with silence that's a real skill sometimes to learn. And particularly if you're feeling anxious, you're feeling a bit under pressure, as we've talked about before, it's very easy to fill the silence with noise, because noise isn't difficult stuff. But actually, usually, if you can generate these gaps, these silences, pauses in a conversation, what comes into that pause is really important if it can be from the person or the family. I'm just reflecting Tanya's really important point. Thank you so much for putting that in the chat, asking another member of the team to try to obtain more information if for some reason a resident isn't opening up with yourself. You're so right. And that's about trust and rapport, and sometimes all sorts of things that it might just not be our day. But if there's a different person with a different relationship, they might be able to get information. I can remember being very worried about about a young person actually who wasn't at all talking about the end of life, although she was terribly ill. And it was just, for some reason, we just weren't connected. I think she saw me particularly in the role of a doctor, which, I mean, I can't do anything about that. But it was our social worker who she talked with, and our social worker said, you don't need to worry about whoever she was. You don't need to worry about her. She's got everything planned, and we know that. And then actually everybody relaxed, because I didn't feel I had to try to ask questions, because actually we'd got that information. So absolutely, I think that's a really, really important point. Thank you. I'm terribly aware that the time, I can't believe it, the time is 2 or 3 minutes off 3:30 already. We just had another couple of things, perhaps top sort of tips that we've come across just to share with you, and to see if it prompts any more questions. But we are quite aware of the time. So the other thing that we have talked about is the breaking bad news thing, and breaking bad news doesn't necessarily have to be about a diagnosis. It could be as big as somebody's died, but it could be something of a change. It could be just a change in situation, and so the news to the person receiving it might be unexpected. It might be bad, but it might be unexpected. And the most useful thing is to remember, if you can, and even allowing for Karen and Kat's and mine, anybody working in the community's perspective of sometimes it can't be beautiful and quiet because we're in somebody's front room. But the most important thing when you're breaking any sort of news is that warning shot, just because that will prepare people for the fact that something important is about to be said. So I usually say something like, I'm sorry, and then it might be, I'm sorry, I need to give you some bad news, or I'm sorry, the scanner showed something. But I usually say, I'm sorry, with a little bit of a pause, and then go on. But the warning shot is really important. It might be if you're in an inpatient facility, a care facility, just asking for people to come in. That might be your warning shot, but that helps prepare, and that helps lessen the risk of the anger and the fear response to it. It's a measured, and people have more chance of remembering, using simple language. And then what Kat and Karen have said about the importance of just sit with people. It's it's tempting to fill the silence with a plan, to try to make it better, we want to try to make it better. We're compassionate, caring people. That's why we do what we do. But the news is the news. We can't change the fact that it might change somebody's life forever, but we can control how we are with people and to create that rapport and the trust. And the most important thing is to have a plan. Even if you don't know what the plan is, the plan might be, I am going to ring up the GP. I will ring the GP and I will come back to you. But having a plan is really important. But I think those are the key things around that. Kat, I don't know if there's anything you want to add to that. And we are aware it is, we're 3:30, but is there anything that you would add to that?
I think the other thing is we often talk about in sensitive communication about maintaining hope. And maintaining hope isn't, oh, we're going to fix everything. Everything's going to be sorted. Let's get the little silver linings and the blue sky thinking. It is genuinely making sure that people realise they're not alone. Sometimes maintaining hope can be as simple as, in our role as a community specialist nurses, we'll give you a call next week to see how you're doing. They're not alone. They know there is someone keeping an eye on things. They know that they can call and get help. If you work in the nursing home, it might be a case of just, we're going to keep an eye on your symptoms, sweetheart, and we'll get the GP to review you. But you just ring that bell if you need anything, and I'll pop in a bit later. You're just letting them know that they're not going to go through this on their own. There will be someone there. And absolutely, hope will be different for everyone, and it will be different for each person as the situation changes. But no matter what happens, we as healthcare professionals are there to support them through this journey. And I remember there was a lovely comment from the teaching that you did in the first session, Karen, and someone had put, we can't change the outcome, but we can change the journey. And that's a really lovely thing to think about. That's what we have the power to do in whatever role we are in. As healthcare professionals, we can support people and make that journey a little easier.
And I think coming in from that, sometimes it's the uncertainty is so difficult for people to manage, and that's just human nature. We unless there are very few people I have come across who just will take life as it comes every day, and that's amazing. But more usual, we like a framework, we like certainty, but for these situations, often it's wildly uncertain. And if we try and make something more certain than it can be, then we have a communication mismatch. and we risk losing trust. And I think we just have to acknowledge it, and we have to and we have to be honest with it. And with that goes the maintaining hope bit, and just saying, you know, I don't know. I don't know what the answer to that question is, but we are here. We will be with you. This will happen, or that will happen. There are things that you can be certain about, even in uncertainty. And it might be that we will come back in an hour's time. I'll come round with your tea, or, you know, we'll come and see you next week. I think, again, just it's the listening, acknowledging it, hearing it, not brushing it aside, and not feeling we have all the answers, because it's that trust and that rapport for the next conversation after this one is really important. Karen, I don't know if there's anything you want to add to that.
No, I would agree with everything you've both said. No, not just because it's gone 3:30, but, but no, I agree. And uncertainty, that's what our jobs are. We deal with that day in, day out, and it's helping families to navigate as best they can that uncertainty, and the patient themselves, because it's their journey, and we're just there to help them as much as we can, and as much as they'll let us.
Yes, that is also very true, and it is up to people with them, you know, people, if they have got mental capacity for the conversation in hand, we have to respect that. And sometimes there are conversations that we cannot have, but we have to respect that.
I think we just wanted to we know we were going over a little bit of time, just briefly, just a couple of other just useful thoughts.
And we can pick more on this for next week as well. Yes,
absolutely. So please put it in the chat, because if we don't get a chance to talk about it today, we'll be able to, you know, talk about this in more detail next week when we talk about recognising dying and end of life. I always talk, and I think I will touch on this next week, about how difficult it is when people want to know how long they've got, because they want to sometimes know to the hour, to the minute. I think if they actually knew to the hour, to the minute, they wouldn't want to know, in all honesty. But people want definite answers, and there isn't a definite answer in life. And in palliative care, we often look at how people are changing over time. So even when someone's actively dying and we think, oh, ye gads, it could happen today, it could happen in the next few days, you know, when the family is still asking that question, you have to be really honest to say, I don't know. And so we look at how people change over time. They've obviously, at this point, maybe they've changed quite quickly, but it could still be maybe hours, maybe later on today. We could still be looking into even a few more days. We would take it a day at a time. And I think it's just really important that we do take it. Just time, just embrace that time, enjoy that time with your loved one as much as you can, and being supportive with them, creating a space for them so that they can be there with their loved one if that's what they want. Because as you touched on earlier, some families, they don't want that, and that's absolutely fine. My aunt, when she was dying, she chucked us out of the hospice at 4 o'clock every day and told us we had to walk the dog and go and have our dinner, because she was the matriarch of our family and she was going to tell us to go off and look after ourselves. And we wanted to stay, but she was boss, and she was boss to the end, and that was right for her. And that's absolutely fine. There's no right or wrong at this point.
I think your word possibility is terribly useful. There is, you know, there is a possibility that this is what's happening. I think that can be terribly useful.
Yeah.
I think the phrases that we want to say are things like, don't worry. We might want to say, it'll be okay. It'll be all right. We want to say, if we've been in the same situation, I know how you feel.
Yeah.
And that's all coming from the heart. But it's not our story. No. It's the other person's story, the other person's journey. And don't worry. Well, they might want to worry because they're leaving people behind. It'll be okay. Will it? What's okay mean? I know how you feel. No, you don't.
No.
I'm me, you're you. So those phrases will come, and I say them from time to time. Yeah. I just can't help myself say them. But as a general rule, if you can find another way to say that, to say those things, we'll be with you.
Yeah.
You know, we'll be alongside, we'll call your family. Something like that is actually in the end more helpful and still shows compassion. And the fact that you're there still shows compassion. But sometimes those phrases can be really difficult and possibly a bit, don't worry. That doesn't feel right at all. So it's useful just to think a little bit about that. But they come from a place of big compassion and warmth. So it's just sometimes training ourselves to say something in a slightly different way is useful. It's useful. Fabulous. Okay. I think we really probably we can talk about communication all the time, can't we? It's such an endlessly fascinating topic. But Karen, any last words? Any last words?
No, because we could talk all afternoon and into the evening and probably into tomorrow. So no, nothing more to say from me. Thank you very much.
We'll pick up some of these pieces, I'm sure, next week. Catriona, anything else to want to add for this today?
No, I think people have done well hanging on today.
Yes.
We really do appreciate it. If you can do the evaluation for us, just so that we can look how we can always improve, we'd really appreciate it. And I'm hoping we're going to see you next week.
Yes, the last one of the series is next week, and it will be all around the recognising dying and the end of life. So I'm sure there'll be a thread of communication that runs through. But in the meantime, between now and then, thank you so much for joining. We hope it's been useful. If you've joined us after the event to look at the recording, we also hope it's been useful, and we look forward to seeing you next week. Take care, everybody, and if you're local to Cardiff, please take care in the rain and the wind. That is definitely happening outside. See you next week.
Thank you.
All right, everybody. Bye for now.
Right. All good. Well done all.
Fabulous. Thank you.
Fabulous.
Ooh,
I've got to dash.
you've got to go.
Thank you so much, Charlotte.
Well done
I'll
all.
send
Take
you
care.
the
See you soon.
slides.
See you next
Take care.
week. See you next week. Thank you, Karen. We didn't get them to talk terribly much, did we? But maybe at the start of next week's, as we're getting people into next week, we can ask people to reflect on today and if there's anything else they want to add. I mean, to be honest, they have been talking about communication haven't they, through the last webinars. So it may be that they feel that they have asked all the questions, that they needed to up until now. We'll see the evaluation anyway. It's such a fascinating, it's lifelong. I mean, if you're curious about people, until we take our last breaths, we will be reflecting on communication styles, won't we?
Definitely. Like I say, it's interesting, isn't it? Especially, I think, harking back to what you were saying about the talk that you went to about how, just as we need to lower our voices and you're not, and it is how we enter a room. How many times are we told to just slink in at the back and make sure no one notices us?
I'm very good at that. That's my forte.
Secretly a ninja. That's what it is.
Yes, exactly.
So if I can sneak in and no one notices, that's perfect. If I sneak back out, even better.
Yes, exactly. But, so listen, how do you want to do next week, folks? What are your thoughts, just quickly?
So I've put together some slides. I was just checking them over. So I've tried to cover, oh God, I'm going back. Hold on, can I go back to the beginning again? So I've tried to take on board, because we didn't get a chance to do recognising dying at the beginning. So I have got a little bit on recognising why it's important to recognise dying, a little bit of background. I had some facts from my data from my quality improvement project, specifically on nursing homes. So I've popped a little bit in there. Then the 5 priorities for care of the dying person, little bit on ACP just to complement what you did in the first session, and then go through the signs, the clinical signs of dying.
Great.
And then I was going to, what do they do next? So contacting the GP, informing family, having discussions. And then I've put a slide in about communication and managing expectations, because I know, especially in nursing
good idea.
homes, that can be quite hard. So unrealistic expectations as to what's achievable within home and hospital, risks and benefits of available options. And I have put a little bit about not all hospital admissions are avoidable. However, what can we do to reduce them at end of life?
I think that's really important, isn't it? Because actually, a fall and a fracture of a femur, it might be the right thing. If
Yeah,
my
might
husband was
be.
here, he'd be saying,
He'd be saying, no,
Yes, right.
he would definitely say that they need to be in.
Yeah.
yes,
And
it
that's
can't
the
be,
thing.
Can't be a never.
And it was when we first did the ACP, I remember sitting in and a very high-ranking nurse for Wales said, ACP, this is about keeping people out of hospital. It's like, no. This is about making sure the right people go to hospital.
Yeah,
And
absolutely.
actually, if somebody doesn't want to go, they don't go. But
Yeah.
if they have a fall, if they've got a fracture femur, yes, they need to go in. And
Absolutely.
if they've
That's-
had their first seizure, it would be good for us to scan them, just so we know exactly what's going on,
But
even
do
if
you
they're
know, Karen, that should be the strap line, shouldn't
Yeah.
it, for advanced care planning? That should be the logo that's on the bottom of all of the stuff.
I know.
It's not about keeping people out of hospital, about making sure the most appropriate people go to
Yeah.
hospital.
The right
It's like
treatment at the right
medication, isn't
time.
it? Right medication, right patient, right bed,
Yes.
right
Yes.
bed, right time.
Yeah.
But it
Yeah.
all comes into that. But that's what annoys me when it's I think they don't see it. And I did a talk
Yeah.
one lunchtime to all the medics, and it was only supposed to be a quick talk, but I think it was about 40 minutes that Bijou asked me to do, and it was fab because they were all really interested in what was going on. And
Yes.
and they understood the whole,
Yeah.
actually, if that person needs to come in, they should be coming in. But
Yeah.
Yes. Yes.
I think that's the
Absolutely.
misconception, and
That's the thing.
documenting the conversations as well, Kat.
Yeah.
We can put something on the
Absolutely.
slides, even
do
if
that.
we,
Yeah.
even if they don't want to talk about it, that we've documented that we've tried to have that
Okay.
conversation, just from an auditing point of view later on,
Yeah.
isn't it? That
No, absolutely.
And actually, you're right. It's about documenting the attempt. So
Yeah.
even if
Yeah.
it didn't go anywhere,
exactly.
actually it's documenting that it had been
It had been
opened.
attempted.
Really
Yeah.
good point.
Yeah.
Yeah.
I'll pop that in on that.
Fabulous.
I've
And I
done
think
a-
health inspector at Wales, that's one of their little things as well, isn't it? When they're
Yeah.
looking at the homes and they're looking at the sort of end of life care, all these conversations have
Yeah.
taken place. So they
we-
do need to have them. I know we end
we-
up having them for them, but we don't need to. We
No.
certainly don't need to. They should be
So-
having them.
We're trying to encourage the nursing homes in Cardiff to start using the care decision. So we're trying to go around and do teaching on that as well. I just can say I've done a quick slide in artificial nutrition hydration because it's something that often comes up. So about peg feeding, about what you might want to do, and about subcut fluids, and then just the bog standard symptom management end of life. So nothing particularly illuminate different there. And then just a little bit on do not resuscitate conversations. And then a little bit on the care decisions. And
Right.
that was what my
Great.
planning plan was.
How many slides in all?
That's 27,
27. Okay.
but that's
In
including
an hour.
Yeah, that's cool. 2 minutes a slide.
I mean, to be fair, one of them's at aims and objectives, one's a title slide.
Yeah, that's cool. We're cool. We're good. We're good. That's all right. We should be. I've got 2 visits rather than 3 next week, so hopefully we'll be back. Hopefully we'll be back in time. But that's all right. I can always wave, saying, "Come on." Oh, there's a watch.
I'm going to
Lovely.
just dash
I
up
know.
to a goal setting meeting upstairs for one of the patients that's going home today. So I just want to disappear
Go
now.
for it and take
Thank
care
you
of the
both.
wind. I've been looking at the wind through your window.
Thank you.
Look after
It's
yourself.
pretty
Lovely
bad.
to see you.
It's
Thanks,
lovely out there
Karen.
otherwise. Bye. Bye.
Bye.
Bye.